Good morning. I'd like to thank the scientific committee for having given me this opportunity. My talk today is Practical Guide to Interpret Visual Fields. I have no financial interest in any of the products discussed in this presentation. So visual field is that area of space where objects are simultaneously visible to the steadily fixating eye. And our visual field is in the shape of a hill. So the hill has two components, the height and the contour. So all the perimeters try to measure this hill. The Humphreys field analyzer is an automated static perimetry. It has a uniformly illuminated bowl in which white light of varying intensity is projected at different points, and we try to find out the threshold. Now, the threshold is the intensity of stimulus, which has a 50% probability of being detected. Fovea has the highest threshold. We have multiple programs like the 30-2, in which the points are 6 degrees apart, 24-2, after the edge points are removed again, and we have the 10-2, which is the central 10 degrees, in which the points are 2 degrees apart, and the macula program, which has the central 16 degrees of the 10-2. In this, the points are 2 degrees apart. We have multiple thresholding strategies. Initially, we had the full threshold. It took nearly 14 minutes. Now, with the time, in order to reduce the time, we have different algorithms such as the FastPack and the CETA. Coming to the interpretation, this is how the visual field printout looks like, and there are multiple zones. So we'll take each zone at a time. First is the zone 1, which has all the patient details. With regards to the patient name, the patient's name has to be entered correctly, initial, the correct program, stimulus size, the correct pupil diameter, visual acuity, refraction. Most importantly, the age has to be entered properly, because the patient's values are compared against the age-related normal. Zone 2 is the reliability indices. In this, this tells us whether a field is reliable or not. So we have the foveal threshold. The foveal threshold should always be compared with the visual acuity. Then we have the false positives and the false negatives. They need to be less than 20%. If they are more, it's an unreliable field, and we get a XX symbol. Occasionally, the machine will also give a stimulus to the blind spot. And if the patient responds, that becomes a fixation loss. Anything more than 20% is poor reliability, or it can also be seen in advanced glaucoma. Right at the bottom, we have the gaze tracker, where it tracks the eye movement. An upward movement means the eye moved up, downward was a blink. So in case we have a skyscraper-like gaze tracking graph, the reliability is poor. Next is the raw data and the grayscale. Raw data is the threshold sensitivity at each and every point in decibels. This is what the patient has done. Grayscale should never be used for interpretation. It's only to educate the patient and to identify false negatives or false positives. False negative is when the patient was initially attentive, and as the test progressed, he became inattentive. So you have a typical clover leaf pattern. White scotomas are seen in false positives. The patient has given a response when there was probably no stimulus. Zone 5 and zone 6, that is total deviation and pattern deviation, are the most important graphs of the visual field. In total deviation, there is point by point difference. That is, the values of the patient are compared with that of the age-related normal. So this reveals a generalized depression. So in this, we need to look at the numerical data as well as the probability chart. The probability values indicate the significance of the defect. Lower the P, greater the clinical significance. This is the normal hill of vision, and this is what a generalized depression. It usually is seen in maybe in case the patient has cataract. Next comes the pattern deviation. Pattern deviation, it reveals focal defects after adjusting the height of the hill of the vision. This is done using the 7th best point. So this confirms a scotoma, as is so shown between these two. Here the pattern deviation shows a lot of depressed points, but if the total deviation shows a lot of depressed points, pattern deviation shows a depressed points only in the superior field. So this is how it is. A localized defect can be missed, but if the height is reduced, it becomes very prominent. Next comes the global indices. We have the mean deviation, pattern deviation, and the visual field index. In case we do a full threshold, we also have the short-term fluctuation and the corrected pattern standard deviation. So mean deviation indicates the overall deviation of the field from normal. So it can either be an elevated field or a depressed field. Elevated fields at times can also be because of a trigger happy patient. So what this does is all the patient's values are added up by and divided by the number of points. The same thing is done for the normal database and it is compared. The difference gives us the mean deviation. Pattern deviation is the resemblance of a patient's field to the shape of the hill of vision. It has a positive sign. A low PSD means it's a normal shape of hill. A high PSD means the shape of the hill is disturbed. Visual field index summarizes the visual field status as a percentage of normal age-corrected sensitivity. It is derived from the pattern deviation plot. It is center weighted. A normal field would have a VFI of around 100, and in case the patient has advanced or fields, it will be closer to 0. This can also be plotted against time to obtain a trend analysis and slope, but for this, we'll need 5 fields and over a period of 3 years. Short-term fluctuation is intra-test variability. 10 pre-selected points are thresholded twice, and the difference is the short-term fluctuation. If it is more than 3, it is unreliable or seen in advanced disease. Corrected pattern standard deviation is PSD corrected for short-term fluctuation. So what one needs to know is all these indices are interrelated and should be considered together for interpretation. Mean deviation, it helps us know the stage of glaucoma damage. Pattern deviation helps in the diagnosis of early glaucoma. In case the field defects covers the entire field, there is a reversal of the PSD. The PSD can again start coming back to the normal, that is in the low values. Zone 8 is a glaucoma hemifield test. As we all know, most of the glaucoma damage occurs in the arcuate areas across the horizontal midline. So in this, 5 sets of points are taken and they are compared. The thresholds are compared. So the report we get is outside normal limit in case the difference of sensitivities is seen less than 1 in 100. Borderline in case the difference of sensitivities is seen in less than 3 in 100. Then we have generalized depression and abnormally high sensitivity. If none of the above conditions are met, then it's comes as within normal limits. Anderson's criteria helps us to know if a particular defect is glaucomatous or not. So for this, what we need is there has to be an abnormal glaucoma hemifield test. On the pattern deviation plot, 3 or more non-edge points in the 30-2 or edge points in the 24-2 with P less than 5%, 1 point with P less than 1%, and the cluster should be in the arcuate area. Abnormal PSD or CPSD with P less than 5%. How do we read a printout? So first thing is make sure all your patient information is correct. It's the right patient, right program, right stimulus size, right age. Then you come down to the reliability indices, make sure they are reliable. After that, just eyeball the grayscale. Don't read too much into it. Go to the total deviation and the pattern deviation. See what type of a defect it is. Try to correlate the defect with your indices. And then finally correlate it clinically before branding a defect as glaucomatous. So these are some of the common glaucomatous defect. We have the arcuate scotoma, which originates at the optic disc, goes around to the nasal field across fixation. This is your paracentral scotomas. This is how they look. And this is the nasal step. So now we'll just come to a few examples. So the first thing what we see is the indices. The indices look okay. There are a few depressed points in the nasal field. GST shows outside normal limit. The PSD is not being flagged. Coming to the left eye, your indices look okay. There are a few depressed points in the nasal field. GST is outside normal limits. PSD has been flagged. So accordingly, as you can see in the left eye, there is an early focus. There's an early notching in the superior neuroretinal rim. The right disc looks near normal. Again, this is the red-free photograph where you can appreciate the notch. Coming to the next example, again, this is a patient, the right eye, the indices look okay. There are, again, depressed points in the nasal part. GSTs outside normal limits. PSD has been flagged. The left eye, your indices are okay. There's a lot of depressed points inferiorly, GST outside normal limit, PSD has been flagged again. So in this, as you can see, correspondingly, you have a superior notch and you also have a inferior disc hemorrhage. The disc here looks maybe a very early superior thinning. So this looks something like a nasal step, and this disc looks kind of okay. But as you can see from this, typically there was an inferior defect, and here we have a superior notch. Coming to the next example, your fields are not reliable. There are a few depressed points in the nasal part. GST is within normal limits. PSD has not been flagged. Coming to the left eye, indices are okay. Depressed points in the inferior and nasal part. GST outside normal limit, PSD has been flagged. So here the right eye disc looks normal. Left eye, we can make out there's a superior thinning with a retinal nerve fiber layer defect, which is again well appreciated over here. This is another example. Your the indices are normal. There's a diffuse depression in the superior and inferior fields. GST is outside normal limits. PSD is also been flagged. Left eye indices look normal. Couple of depressed points in the nasal field. GST is within normal limits. PSD has not been flagged. And if you pay attention to the gaze tracking, this is what the typical skyscraper, a lot of patient fixation has not been proper. So as you can see in the right eye, there is a bipolar notch. There is a retinal nerve fiber layer defect. There's a superior disc hemorrhage. And here again, there is a superior disc hemorrhage. Though the field appeared to be normal, there is a disc hemorrhage. So this is why we need to clinically correlate our findings. This is another example. The indices are okay. There's depression in the nasal part of the field, like a nasal step. GST outside normal limit. PSD has been flagged. Indices look okay. Diffuse depressed points superior and inferiorly. GST outside normal limits. PSD has been flagged. And as expected, we have an advanced cup bipolar notch with a very broad wedge-shaped RNFL defect. And here it looks okay. So this is another example. Indices look okay. You look at the difference between the total deviation and the pattern deviation. So the whole total deviation field appears depressed. On pattern deviation, the depressions appear less. Here again, the indices look normal. Grossly depressed points on the total deviation. Pattern deviation, you're seeing only few. Both of them, the GST is outside normal limits. PSD has been flagged. So as expected, the image was not, the patient has, as you can see from the image, patient has cataract. So that is why there was a difference between the total deviation and the pattern deviation. And in spite of the advanced cataract, we can make out in the right eye, there is a advanced cupping. Left eye appears to be normal. And this is my last example. The indices are not reliable, very extremely depressed, a lot of depressed points superior and inferiorly, GST outside normal limits, PSD has been flagged. Here again, the false negative is 71%. In this, it was 28%, very high. Grossly depressed fields, GST outside normal limits, PSD is also flagged. And this is the disc. So maybe a mild inferior thinning with a retinal nerve fiber layer defect. Here also we have a retinal nerve fiber layer defect with an inferior thinning. As you can see, the field does not correlate with the disc changes. Patient does have suspicious disc changes, but fields are not correlating, probably because extremely unreliable fields. So to summarize, in case we see an abnormality, first things we should, when we are analyzing a field, first figure out, are we really seeing an abnormality? And if that abnormality is consistent with glaucoma, And if it is, then these findings have to be clinically correlated before we brand a patient as having findings consistent with glaucoma. And if they have, then further fields would only be necessary to know whether the defect is stable or progressing.